With this, we will move on to the next topic. The second topic, which is scheduled for the day, is on ABO incompatible transplantations. And today, for that, we have two very eminent moderators, Dr. Kishore Babu sir and Dr. Ravi Shankar sir, both from Manipal hospitals. And with that, I will hand over the session to both our moderators to introduce our speaker for the day. Over to you, sir.
Anil is my very good friend, and he's a transplant physician and consultant nephrologist at global hospitals since last 1.5 decades. And he is very much interested in transplantation, including ABO incompatible transplants and highly sensitized this thing. And hand over to Anil to deliver his talk.
Hello. Good evening. Thank you, Dr. Kishore Babu sir and Dr. Ravi Shankar sir. Thanks Emcure for having this platform for us to share our views on increasing the donor pool. ABO incompatible. Yeah, this is my overview of my talk. We all know that ABO incompatible transplantation could change the immunological barrier, which was considered initially as an absolute contraindication for transplantation. One such barrier is the ABO blood group incompatibility. And kidney transplant across the ABO blood group barrier has the potential to expand the pool of donors and increase the availability of transplant organs and decrease the prolonging time for patients who will be on the waiting list for a kidney. So this is Karl Landsteiner, is a Nobel laureate. In 1900, he introduced different blood groups. This is a study from CMC Vellore. They showed that in South India, the common blood group is O blood group, which consists of about 38%. The next common is 32% is the B blood group, then is the A blood group. In A blood group, we have two subcategories, A1 and non-A1, or A2. A2 comprises around 9%. A2 blood group, they have less antigenic, and in fact, they can be transplanted with less risk to non-A blood group. The least common is the AB blood group, which is compromises around 6%. The likelihood that two unrelated individuals are identical is about 37.5%. Compatible is around 26.7%, and incompatible is around 35%. So what we want to say is around 1/3 of the population we are incompatible. So what happens is, in a scenario where we are in where the nuclear families, and we have to wait at least for around 3 to 4 years for getting a deceased donor. We are left with, many of the patients are left with no incompatible donors in the family, and they are not able to get a transplantation done. So what happens when we transplant a patient with an incompatible donor, whether it is kidney, liver, or heart? So the pre-formed anti-donor ABO antibodies in the recipient will act on these antigens, which are not only present on the RBCs, but also on the platelets, epithelial and endothelial cells, and there is an hyperacute rejection. So the mechanism of hyperacute rejection is in the endothelial cells of the graft, the antigens which are present are recognized by the recipient. B cells produce anti-A and anti-B antibodies. So these subsequently there is a complement activation, and there is endothelial injury, and bleeding happens. There is also, because of the increased Th1 immune response from the CD4 helper cells, there is increased activation of the pro-inflammatory cytokines, and subsequently endothelial cell activation stimulates the tissue factor pathway with the factor 7, and the coagulation cascade is activated. There is formation of thrombin, and which in turn converts fibrinogen to fibrin, and there is a thrombosis, and this is how there is a severe hyperacute rejection. So what to do to prevent this is, one is we can the plasma cells which are produced by these B cells, rituximab can be acted earlier. There's to splenectomy was done. Another method is removing these anti-A and antibodies by doing various apheresis procedures like plasmapheresis, immunoadsorption, or double filtration plasmapheresis. And also recently bortezomib, which will also a plasma cell acts on the plasma cells, and also the final complement pathway can be tackled by eculizumab. So going to the history of ABO incompatible transplantation, after the blood group was introduced in 1901 by Landsteiner, the first in 1952 Hume et al. They started the 8 ABO incompatible transplant. All of them graft rejected, and subsequently Murray, Gleason, all who tried. So there was the outcome was very poor. So what they concluded was ABO incompatibility is an absolute contraindication, and these grafts never tend to function after the transplant. That was the conclusion given. So, but what happened after 1981 was Lepek et al. They introduced by doing plasma exchange, the grafter's survival was there and it was effective. And 1985, Alexander et al., who is also considered father of ABO incompatible transplantation. So he did pre-transplant plasma exchange with splenectomy, and the graft came up to 74 days. And so, and subsequently the Japanese people, especially the Tanabe group and all, they have performed more than several thousands of transplants, because in Japan there is a disease donor transplant doesn't happen. So it's mainly they rely on the living donor pool. So they are 30% of their transplants will be of ABO incompatible transplants. So what Alexander did in the initial periods was, so they gave donor-specific platelet transfusion, plasmapheresis, they did splenectomy, and with the triple immunosuppressive regime, that time it was cyclosporine azathioprine. So they gave polyclonal antibodies, and that time they gave substance A or B. This is substance A is one, it is similar like what we give FFP just prior to the transplant, which contains coagulation factors mainly to prevent bleeding. Those they did were the recipients who splenectomy was not done, they rejected, hyperacute rejection was there. So over time, what has happened, there is several evolution of the protocols. So initially in the 1989, when Alexander et al. Started, initially it was splenectomy, and from 2005 onwards, rituximab came in to replace splenectomy, and several apheresis procedures were done. Initially, both pre and post transplant were done. Now there's the necessity to do post transplant apheresis has reduced, and IV immunoglobulins initially was there. Now the people are, it's a questionable whether it is useful or not. So a lot of evolution. So the basics of desensitization in ABO incompatible transplant is, one is rituximab, which is given pre-transplant, apheresis procedure, triple immunosuppressive regime prior to transplantation, and on-demand antibody depletion post-transplantation, and induction therapy. This is the basics. What in general, there are a lot of modification of the and different protocols. So there is no fixed protocol anywhere in the world. So these are the dilemmas which I want to address one by one. So what are the different methods, and what should be the target pre-transplant titers? What are the different procedures which should be preferred? Do we need to monitor post-transplant titers, if at all? And what do you do if it is increased? What is the dose of rituximab? When to use it? What is the role of IVIG, if at all we use it? When to start maintenance immunosuppression? What is the ideal induction agent? So, so there are three different methods for measuring the isoagglutinin titers. The gold standard is flow cytometry. Until recently, we were doing tube methods. That is a tube glass method. So now most of the centers do the column agglutination method or the gel card method, which is more reliable. What happens in the tube method is we used to, like if at all the titer is 1:32, so it can be either between 1:16 or 1:64. So intra-hospital variation and inter-hospital variations were very high. So nowadays we do column agglutination method. Flow cytometry is done mainly in Japan. We don't do in our country because it is very expensive. This is how gel card method the reports are interpreted. So this is 0 to 4 plus. So it is categorized and reported. The, so what the target pre-transplant ABO titers? The higher pre-transplant titers, there is a poor outcome. This was shown in many studies. Majority of the centers all around the world, they target around titers between 1:8 and lower. In Japan nowadays, they are doing the titers, pre-transplant titers are 1:32 and 1:64. They've gone up to 1:128 also in many of their studies. However, the 1:64 is the one that the minimal titers they prefer. So what the Indian working group recommends is pre-transplant IgG-AB titers of less than 1:16 should be taken as a cutoff to go ahead for ABO incompatible kidney transplantation. The outcome of AB incompatible transplant depends on many factors, and therefore patient and caregiver need to be counseled that titers are not the sole factors in determining the outcome. These are the different apheresis procedures. This is the plasma exchange where the plasma is separated. So what is the flip side of this? There is large amount of substitution fluid is required. When we give plasma, there is a lot of protein allergy. Patients, there is a high risk of infection from the substituting fluid, and also there is a bleeding risk. So initially, plasmapheresis, what we do is the replacement fluid is used as albumin. So when we are the pre-transplant, the last plasmapheresis procedure, we use either the AB plasma or the donor-specific FFP is being given mainly to reduce the bleeding risk. Some of the centers, they do a fibrinogen level prior to the transplantation. So and estimate, and if there is a low, then you replace with cryoprecipitate. DFVP is a modified form of plasmapheresis. After the initial plasma separation, the separated plasma goes through another filter called as a plasma fractionator. So where what happens is you have the plasma which contains the IV immunoglobulins and also the albumin. So in this is the cascade filter or the plasma fractionator. So the immunoglobulins which are pathogenic are separated, and the albumin returns back to the patient. So what happens is it is a more selective than plasma exchange. It returns the purified plasma to the patient. Minimal loss of patients' own desirable non-pathogenic substances like albumin. And also we need minimal substitution. Probably a liter of albumin, 5% albumin is more than enough, and there is no need to give FFP. The most ideal one would be the immunoadsorption method. So here the separated plasma goes through an immunoadsorption column. There are specific columns. Say for example, you need a patient B blood group, you are want to A is a donor, we need A column. So likewise there is A, B and AB columns. So the main advantage is here is so you don't need any replacement fluid. Large volumes of plasma can be at the same time. 4 to almost up to 8 to 9 plasma volumes can be at a time can be processed, and there is no need to substitute, and patient withstands the procedure very well. But the main drawback of this is the cost. Actually, it is quite expensive. So which apheresis procedure is preferable? It depends on the center's choice. It depends on the financial status of the recipient. So for example, you want to use an immunoadsorption filter and do at least 2 cycles in a corporate hospital. Probably the cost may be another 6 to 7 lakhs extra for the recipient. So it's quite expensive. It depends on the anti-ABO titers. The higher the titers, probably if there is a need for, if the titers are more than 1:256, probably you need of ABO column. And depends on the center's infrastructure and the technical expertise of the staff. However, there is no differences in the outcome, whichever method you use for the antibody removal. So probably this diagram shows a simple tailored desensitization strategy. If the titers are less than the 8, you can just go ahead with the induction and maintenance therapy. If it is 8 alone, or rituximab alone is enough with immunosuppression, maintenance immunosuppression. 16 to 64, probably rituximab, DFUP, and induction therapy would suffice. And more than 64, probably we may need an immunoadsorption. Do we need to monitor post-transplant isoglutinin titers? Routine measurement of the titers after transplantation is not recommended. It is of clinical significance only if the rising titers are associated with graft dysfunction. Post-transplant plasmapheresis may be necessary if there is graft dysfunction with increasing titers, like for example, it suddenly jumps four-fold high in the baseline, and and no need to monitor after once we cross the 2 weeks time. That is the time where the patient develops accommodation. And what is the dose of rituximab and when to use it? B cell depletion by rituximab has facilitated the expansion of ABO incompatible transplantation by obviating the need for splenectomy. The drug is given anywhere -1 day to -30 days pre-transplantation as per several protocols. But it should be given at least a week before starting plasmapheresis because whatever you give may be washed off. Cross match, it is better you do the cross match test before giving rituximab, because when you do a cross match after you give rituximab, at times you may get a false positive cross match test, or even if you have flow cytometry, cross match also will be a false positive. So it's better do a cross match prior to by giving rituximab. And dosages instead of the standard dose of 375 milligram per meter square. So many of the studies have shown 200 milligram is more than enough actually. And the people from Calcutta, they have used even 100 milligram. So this is study shows the CD19 cells, the drop, the fall in CD19 was equivalent even with both 200 and the standard of 375 milligram per meter square dosage. And you can see here in this slide, the graft survival and the patient survival did not matter whatever dose we use, either 200 mg or 500 mg. And what we see here, the infection risk, especially when you give rituximab 500 milligram or 375 milligram per meter square with an ATG induction, the infection risks are very, very high. And if at all the patient develops rejection and he gives steroid pulses, the incidence of infection is more than 60%. That is very high. What is the role of IVIG in ABO incompatible transplantation? Prevention of anti-AB antibody rebound in the early phase after transplantation would be prevented by using IVIG. It may also reduce the infectious complications because after plasmapheresis, a lot of the protective globulins are removed from the body. So probably by giving IVIG, the infectious complications may be reduced. These are by several mechanisms how IVG acts, and it's by preventing this anti-AB rebound. But the drawback of this thing is it is also these IVIG preparations contain some anti-ABO antibodies. So these may give a rebound rise in the titers, but and also it has shown that in some cases, case studies, it has caused rejection, AMR as well, because of these antibodies present in the IVIG. So what is the Indian Working Group recommendation is IVIG use is not routinely recommended. IVIG contains anti-AB antibodies that can lead to increase in titers. When needed, it should be used in low dosage after plasmapheresis cycles, and also with the batch having low AB titers. That is difficult to find out. Lastly, accommodation is the resistance of an allograft to AMR despite the presence of significant level of anti-ABO antibodies and C4D deposition. Accommodation differs from tolerance, where in tolerance you don't have any DSAs or anti-ABO antibodies, and they do well. Whereas accommodation, even though they have DSA and they still do well. So these are the proposed mechanisms how accommodation happens, mainly because we are removing all these antibodies, their affinity towards the antigens are decreased, and also because of the inhibition of the complement pathway, the endothelial cells have a phenotypic, they take means the stage where they are the further complement activation and the thrombin formation are reduced. This is because many of the protective genes are activated, like these anti-apoptic factors like hemoxygenase, and also there are some complement regulatory proteins like CD45, 55, and 59. So they prevent this activation of the complement pathway and subsequent rejection. So last question is it worth doing it, ABO incompatible transplantation, when compared to, because in the West, actually, the ABO paired exchange, as Dr. Girish told, it is more preferred than ABO incompatible transplantation. So, but the Eastern people, especially the Japanese people, don't think so, because their 10-year survival is as comparable to the compatible transplantation. So, though here we see some differences, but in the recent studies, this is the Tanabe's group of study where from 2005 to 2030, here we see the patient survival and the graft survival. In fact, it is better in the ABO incompatible transplantation when we compare to the compatible transplantation. And their protocols are very simple. So they use rituximab minus 5 to 7 days, 200 milligram. Then the triple immunosuppression. They maintain a very low TAC levels, around between 6 to 8 in the first month. Their average use of DFPPP is only 1:1 to 3, and basiliximab induction and induction of 500 milligram methylprednisolone. This is the German experience. What we see here in the first month, this is the same in Indian scenario also. In the first month, we have the patient survival is affected because of infectious related deaths, and then after the graph does not dip down. It is almost same compared to compatible. The same thing is there is an initial dichotomy in the graft survival in the first 3 years post transplantation. Then after the 3 years, almost it is the graft survival is equivalent compared to the incompatible transplantation. This is in a meta-analysis of 26 single centers. This was published in CJASN in 2018, where around 4,943 compatible patients were compared with 1,346 incompatible recipients. So what we see here at the end of 1 year, the graft survival is almost equal. But there was the death related to infections were almost 49% when compared to 13% incompatible. The rejection rates were higher, and also deaths due to non-viral infection like sepsis were also higher in the ABO incompatible transplant. The conclusion of this meta-analysis was ABO incompatible kidney transplant treatments, although they have a good outcomes, albeit they are inferior to the center-matched ABO compatible control patients. So, but when we compare the incompatible to the other situations like deceased donor transplant and the deceased donor HLA incompatible transplants and the living HLA incompatible, the best survival is in the living non-sensitized patients. Then is the living sensitized patients. Then ABO living patient, incompatible living kidney transplant patients. So then only is disease. So when we compare probably a patient who can, if at all he's got an incompatible, if he has an option of going for an incompatible ABO transplantation versus a disease waiting on a waiting list for a disease donor transplant, people would feel that to go ahead with the ABO incompatible living donor transplant would be a better choice, provided he doesn't have a chance for a paired exchange transplantation. So I would present this is our small data of what we did transplants in our hospital. We from 2016 to 20, we had around 24 ABO incompatible transplants. Majority were males, and 7 were diabetics in our study. And the donor recipient pair was, so majority was B to A, and we had one A2 to O, one patient, and others from A1 to O also was a significant. So what we find is the O recipients have got a very higher antibody titers, and also the risk of rejection also is high in O recipients. Antibody removal procedures, in 4 of them we didn't do any antibody removal procedures because their anti-ABO titers were less than 1:4, and 15 of them we did just plasma exchange. Only 1 of them we did double filtration plasmapheresis. Why only 1 was because we felt getting a EVA flux filter with the plasma filter and doing this thing, the cost almost is equivalent to that using immunoadsorption column. So we had only 1 DFPPP, and 4 of them we did immunoadsorption. So though initially we did a lot of plasmapheresis, even for titers up to 256, but later on we felt that the risk of infections were higher when there is a requirement for more than 4 plasmapheresis. That's when we changed our protocol. So what we do is less than 1:64 we do plasma exchange, and more than 1:64 we go for immunoadsorption. So what the Indian working group recommends is immunoadsorption becomes more efficient in reducing antibody titers if more than 4 plasmapheresis sessions are needed. Hence, it makes sense to use this method if the initial antibody titers are more than 1:128. So coming to the graft outcomes, our pair two, we lost two patients and two grafts failed. So around and we had six rejections. That contributes around 16% of the rejections. Majority were antibody-mediated rejections. One thing what we found, those who had rejections in the first month post-transplant. So when we followed them, so later onwards their graft function was slowly worsening, and these patients also had a chronic the rejection in the form of transplant glomerulopathy. Uh, Infections, we had all types of infections, especially the for initial transplants. So we had tuberculosis. We had in two patients, one had a miliary tuberculosis, one had a fungal infection. So we improved, however, and we had three COVID-19 in the last year. We had three patients who had, though they were all mild to moderate respiratory failure, all of them improved. We had one herpes zoster. Infection rates are high when we compare to compatible recipients. So the lesson learned in our study was in our 24 patients was rituximab. When we use 500 milligram with ATG, that's what we used in the initial transplant. The risk of infections are very high. So if there is a need for more than 4 sessions of plasmapheresis, the risk of bleeding increases, and also as well risk of infections. Infection risks are higher in patients with pre-existing diabetes and also in NODM. Rituximab and early start of triple immunosuppression decreases the risk of rejection. High baseline IgG titers doesn't mean poor outcomes, and also low IgG titers also doesn't mean that the outcomes are very good. If sensitized, it is ideal to look for a DSA, preferably by single antigen bead before transplantation, because so we have seen that those patients who develop rejection, we don't know what is the cause. They would have got a pre-transplant titers of 1:4 or 1:2. Still, they develop a rejection. Probably, if you look in detail, if they are sensitized, it's worth doing a single antigen bead and see for any donor-specific antibodies. So I was happy to share with you that I was part of this Indian working group recommendations. So when I sat in 2018, so along with other senior faculties. The conclusions is ABO incompatible transients, which was once considered absolute contraindication, is no longer the same. Long-term outcomes with the ABO incompatible renal transplant using current protocols are comparable to the ABO compatible renal transplants. So especially the outcomes what we see in the Japanese group, we are much reassuring. ABO incompatible transplants have expanded the living donor pool significantly, and transplantation in the presence of major ABO incompatibility, however, place the patients at somewhat a higher risk of early rejection, infection, and also infection associated death. And still, I would think that paired exchange transplantation would be more preferable than ABO incompatible transplantation, provided we improve the logistic of paired exchange transplantation. Thank you.
That's a good talk, Anil. It was very lucid and then very useful talk. Yeah. And then I'm sure that most of us will be following similar protocols what you have done in your center. Yeah. But I have few questions, like if you have siblings or parents ABO incompatible transplant, what is your are you using ATG in all patients, or
only the initial 6 to 7 patients we used ATG, and after that we stopped using ATG. We are using only basiliximab. So what we observed was initial patients we used both 500 mg rituximab and ATG. So at least 4 out of those 6 patients we had a very severe infections. I think Dr. Deepak was there with us that time. We had a very horrendous time. In fact, one patient had a meningoencephalitis, severe hypotoxicities, tuberculosis, all sorts of infections we had. So we were scared, and our interest towards ABO incompatible transplantation was lost. We thought it is not worth doing ABO incompatible transplantation. But when we changed the protocol, that has given us some hopes.
So no, I mean, better not to use it.
Yes.
Use ATG in almost all patients of ABO compatible if they are HLA matched also. That is what the question is, because the cost and the infections are much higher when you use ATG in addition to the cumulative immunosuppression is high. That's what I personally. Able to hear?
Yes, sir. Now I'm hearing.
Achha, the other thing you said, Japan, they said that, they have used only 2 DFPP, isn't it?
Their average use is 1:3 DFPP, and they go, if it is 1:64, they go ahead with the transplantation.
Yeah, but that's what they're taking the higher cutoffs. But in Indian scenario, we go at least 1:16 and below we accept. Yes. So do you think that
even the people from Calcutta, they are doing 1:64 of lately, especially in the Rabindranath Tagore's group of in that hospital, they are doing 1:64. But I sometimes feel that I don't know what others say, whether the Eastern group of the population, when we compare to the West, is there any differences in their antigenicity, immunogenicity compared to the Western people? And we Indians are different compared to them, because we see whatever the outcomes they project, they are much better when we compare to the other part of the world.
Yeah, that's what our observation is. Even the column, we struggled sometimes. The titers 1:64, 1:120 to bring down to 1:8. Sometimes to some EFPP in addition.
Your voice is not audible, sir.
Sir, can you switch off your video and can speak? The voice will be clear. So once you switch off your video.
That fine? Hello?
Yes, sir.
Yes, sir.
Yeah, that's what we struggled in some patients after using the column also.
Yes, sir.
Do you think that we should do a DFPP or plasma exchange if one column is used and then cost is almost like 4 lakhs?
So
nowadays,
what we are doing is hybrid
methods.
Actually, we are sometimes to save cost, we are doing both plasmapheresis and immunoadsorption. Probably if you have a titers of more than 1:128 or so, you can use you can start with the plasmapheresis, then you followed by immunoadsorption. Immunoadsorption, though they say the company says we have to use only single use, we have been using at least one reuse has been done. But more than 2 reuses, what happens is that their efficacy is significantly reduced. So it is not worth, and there is also a risk of infections. So probably one plasmapheresis followed by immunoadsorption would help actually, especially in situations you have higher titers, like more than 1:128 or 256 and above.
Okay, Kishore, any other questions and others? Yeah.
I think from the
I had a question on a lighter note. That was an excellent presentation, Anil. Thank you very much. I've got a difficult task to follow, but I had a question on a lighter note. Any studies done to look at the mental and cardiovascular health of transplant physicians doing ABO incompatible versus those who are not doing it?
Yeah, as I told, actually, after the first 3-4 transplant, I thought it is not worth doing. And for at least next 6 months, we didn't do any ABO incompatible transplants because it was very stressful.
So especially the titers are high, 1:128 and above, then the cost will be definitely high, man. Because if you use 2 columns, then you're gone. Almost like 60 to 20 lakhs it is coming. So we have to look at that fact, and there is no certainty even it's 1:8 titer. You can't tell the patient that you are absolutely safe 1:8, because I had a patient 1:8, he rejected on the 5th day. That's what is the question. So it is very difficult to convince the patients that, after doing everything, you are reasonably safe. we can't tell. Even the titer 1:4, Ravichandran had rejections in Chennai. So that's what he says, that this titer is not really going to tell anything. So we don't know which patient will reject. Yeah, as you said, that probably you should do a DSA and then see that whether they have any single antigen beat antigens. Like, no, you can do that. That also might cause, or some anti-endothelial antibodies. I'm not very sure. So those are the areas, the gray areas. We don't know what exactly is causing rejection in some of these patients. Though the titers is 1:8 below, even 1:4. What I heard.
Still, there are
there was a
questions.
There was a question from Ganesh Prasad. Can transplants done with titer of 1:32 without any desensitization, you can do it, he's asking.
Yeah, that's what the Japanese people are been doing. They are doing up to 1:64. But in India, only the group from Calcutta, they are doing with the titers of 1:64, and they have got a good outcomes. So, but when we are starting, when we are still, all of us, majority in India are doing up to 1:8. Probably we can go to the next level of 1:16 if we get a confidence to hold it next level.
There's another similar question. If the titer is less than 1:16, what part of desensitization can you avoid or not perform? Can you reduce the immunosuppression?
It is still worth to do give rituximab, do at least 1 or 2 plasmapheresis prior to the transplantation, because it is we in fact we had one patient whom we which was, as Dr. Ravi Shankar sir told, it was 1:8, and we just gave rituximab and went ahead. There was still a rejection. So it is worth doing 1 plasmapheresis at least before you go ahead with the transplantation.
Okay. Then
because you are not only taking care of anti-ABO antibodies, if at all, because if you are not doing a strict sense of single antigen bead and seeing for some unknown DSAs, so some of these DSAs are taken care of by doing a plasma.
So another question is use of anti-BAF therapy to reduce ABMR. Any anti-BAF therapy?
Not much idea, sir.
And anti-BAF is not available in India. It is only in US, and I think Girish will know. Maybe Europe also it's available. BAF is not there in India.
Europe also there.
Yeah.
So these are the questions from the audience.
Anil, I have one quick question. I had one COVID positive recipient and donor who underwent transplant after becoming COVID negative. Of course, it was ABO incompatible. Mother to son, titer was only 1:4, but I was really scared to do without doing any plasmapheresis or desensitization. Though it was 1:4 and mother to son more than almost 50% match. So to be on safer side, I did 1 DFPP and did transplant. So what do you think?
The fear will make us to
correct. Yeah, number of transplants
at least. But we feel that at least up to 1:8, we can give rituximab. Probably start immunosuppression much early.
That's we are doing. 2 weeks we are starting.
2 weeks we are starting.
Rituximab and start immunosuppression early. So that is the key to this thing. So probably up to 1:8, we can go ahead without.
Thank you.
Yeah, I think what Vishwanath is telling is when the titers are below 1:8 or something. So anyhow, our standard immunosuppression is 2 weeks is there, rituximab is there. In addition to that, what we should do, I think, as you said, that plasma exchange would be fine, because to cut down the cost and then bring down the titers below 1:4, something like that, and go ahead with the transplant, explaining the risk. But there is no titer we can say that guarantee saying that you will not have rejection. So that is the crux here. So it's very, very difficult to convince the patient that you will not have any problem, even with the titers of 1:4. So we have to always tell them that, yeah, the chances of rejection always will be there even with the titers of 1:2. There are other factors, maybe anti-endothelial antibodies. Maybe they might have, earlier we were not having DSA single antigen bead, but now we have DSA single antigen bead. Probably we should do that. And then probably what Anil said, ATG and all is overusing. I think some of these patients, we simply use ATG just like that 100 to 200 milligrams, the risk of infections are pretty high. When there is HLA matched ABO incompatible, probably we can avoid ATG. If at all, like Dr. Sundar's protocol, 1 dose of ATG, something like that, we should use rather than giving heavy doses of ATG. It will cause a lot of infections. So I don't know, the Japanese, because they do large number, they are more confident to get over with 1:64. If you do more and more transplants in India, yes, probably we also will come to stage that 1:16, 1:34, like Calcutta people are doing, so we can go ahead with transplant. So probably Sundar and Chako sir give some points. So.
My experience is very limited about ABO incompatible. So I request my guru, beloved guru, Dr. Chako sir to answer this question.
You're passing the buck to Chako sir.
Mike, sir.
Sir,
Muted, sir.
Mute, sir. Unmute, sir.
No, I think the administrator can unmute.
The sir will only have to do it from his end.
Yeah, he has to do, sir has to unmute.
There is one mic button, sir. Yeah, done.
Yeah.
Yeah, you have to unmute, sir. Yes.
I really don't have much experience with the ABO incompatible, except that we did one very long ago in Bangalore when I was there, and we were all very ignorant, and even with a high titer of 1 and 256, we went ahead and did just 4 or 5 plasma exchange, gave some IV cyclophosphamide and did the transplant. Fortunately, it was a mother to son, and I think he's doing well even now. But apart from that, I think since we have been, Sundar and I have been given elderly donors, I think.
Elderly donor, elderly nephrologist also, sir.
I think we should stick to that mandate and not try all this. No, I think it's
out of syllabus.
No, I think it's a very useful thing, and I think it's quite safe in good hands if you stick to the recommendations. And I think the results actually published results certainly show that it is as safe as ABO compatible. So I would encourage the youngsters to go ahead and do it.
I think if the cost is covered by government or insurance, then the impact is less. Something happens, rejection or whatever. I think that is the key in this process of ABO incompatible or any of this transplant. I think if somebody is paying like NHS or insurance, then something happens, there's no problem. That's the issue.
Yeah, I agree. Especially in the private sector, if the titer is more than 1:256, then you are mandated to use columns. If at all, maybe 2 columns, then the cost would be nearly 16 to 18 lakhs. So the titer matters here because we can't get away from the titers also. And then when the titer will come down to what level with 2 columns or 1 column, we don't know. So the higher the titer, then the cost will be definitely, because you are going to use the column. Plasma exchange is cheaper, column is definitely expensive. If you are using 2 columns, then the cost would be almost like 5 to 6 lakhs.
Even after that, if the patient asks, can you give guarantee? Is there nothing?
Yeah, that's what they will ask many times. What
spend
is
more
that
money, more guarantee. And spending more money, more guarantee.
Oh, for that I have a standard answer, Ravi. I tell them, you give a guarantee that I'll reach home today, and then I will guarantee your survival. So they don't.
Especially Bangalore road, sir, I understand.
Actually, putting it forward, sir, ESI is given a special package for ABO incompatible transplant where they are releasing around 6.5 lakhs. That is not enough to cover for the plasma.
That is not enough. That is not enough. That's 6 lakhs.
No, actually, seeing the results of ABO incompatibility, that is the reason I switched over to the other expanded programs like old age donors, because the patients get to do well, the cost is less. And here, more than anything, it is the uncertainty where we think the problem will not happen. There, the problem happens, and where we feel the problem will not happen, there, it's a mix of. Still, I think we are not sure how to handle the ABO incompatibility.
That is the magic of transplant. You need an astrologer.
I agree.
You hire an astrologer and keep.
Vastu also. As Sanjay, you rightly pointed, I also feel that we should go for little elderly donors up to 70 and all. Probably if the GFR is good, we can take. And then some of them, fathers and parents are coming forward, but they're early diabetics. So I have accepted 1 or 2 early diabetics because there is no other donor in the family. They can't afford ABO income.
I think next Ram Mohan Bhatt is talking on that, Ravi. Next topic is that.
Sure.
Discuss
So
once.
I think we'll close.
We'll close the session.
We'll close the session, because the time is getting a lot of things to discuss. So we'll go to the next session,
I thank Dr. Anil Kumar sir for this wonderful talk on ABO incompatible transplant and all the panelists and the faculty member, where we had a wonderful discussion.